It's my valve case. Here we'll talk about a male, 79 years old, with NIHA class 3 classification. The cardiovascular risk factors were arterial hypertension, dyslipidemia, diabetes, had also sleep apnea syndrome, and normal kidney function. The Euroscore 2 was 2.65, and the CTC score was 1.8, and the logistic Euroscore 5.48%. This patient had a coro, and he saw here that he had an intermediate lesion in the LAD. But since he was a diabetic and above 70, we decided to do an angioplasty. We placed there one stent, 3.512, with a good result. The pump function in the echocardiography showed like normal function of the LV and severe stenosis with a mean gradient of 65. We see that he has a very nice left ventricular ejection fraction, normal sizes, very calcific valve here, with no dilation of the annulus as long as it's described. Here we see also there has a small trivial MR, but not something important. I apologize for this signal here. It's not the most correct because it comes after an extrasystole, but we can appreciate that still the mean gradient is high, and there's no doubt that there's a severe stenosis of the mitral valve, of the aortic valve. So this is the coro. Actually, you have a good RCA. And the problem of the LAD was here, so that was actually nicely treated with one stent, as I said before. There was no problem here. The rest of the vessels were actually nice, not big calcifications. So honestly, after Dr. Nino's presentation, I don't have a lot to say. It was an impressive presentation. So the first India 18, 19 in Europe. The design was already described. The size range is a big one, and this also helped here in this case. That's why it was actually chosen, and the studies were already presented. This is the valve, and it looks actually very stable here. We have this skirting, which is very special on it, and as I said, we have plenty of sizes to choose from. It is actually, what is the novelty of this is the ease of delivery, and we have less vascular complications, better precise deployment, especially in small annuli, and it is actually more friendly for the operator. Has the stent and the balloon inside, so it's just delivering an implant. Paravalvular leak reduction because of the skirts, and hence hemodynamics. And as I said, the studies were actually described. This was also described as second dense band that helps the operator to see where exactly is the height of the annulus and annular plane and place the valve. The positioning is also better then. That is the CT angiography of this patient, and the measurements. We have the area delivered 24.1, and since we have also calcification, but it's asymmetrical calcification, we can see it here, 24.2 is delivered in the TAVR protocol, and there is calcification of the tricuspid valve, and we go actually to the access. The access enough good to do the TAVR through the femoral, although there is a diffuse calcification on the vessels as it's expected from a diabetic patient. So we proceed to the video, which shows to put a 24.5 millimeter, which actually in this patient, according to the CT measurements, would be very precise. Go to the video. Yes, I will go a little bit fast forward here. We go through the right femoral artery. We use always ultrasound guided puncture to reduce complications. First is the local anesthesia, of course. Here's the puncture. Nicely made is the preparation. We do the pre-closure devices we used here, 2-Pro Glide. Here is the preparation of the valve. Here we do the delivery system, the seat first. This is the pre-closure. We do like two of them. Same time, valve is prepared. So 14 friends then will follow. So the seat is inside, and this is the Python 14th friends.
So, Vlas, in the meantime, how often do you predilate when you use the MyVal?
I like predilation, personally. I'm used to it because I use other platforms as well that require predilation as mandatory. So if I see, I would predilate this valve, for example. There's a lot of calcium in both leaflets.
Even with the MyVal, despite having
I think
balloon expandable valves.
It makes your life easier. You don't have to agree with me. I know Theo disagrees with me. He's done more MyVals than I have, but in Turkey, for example, they do lots of direct valve positionings, and I've seen that. But
so Theo, you predilate a lot?
Actually, I'm still with the issue that predilation in bicuspid aorta, every time predilation, horizontal aorta, predilation. And if the amount of the calcification on hockey puck waves are over 2/3 of the circle, predilation. But the beauty of the MyVal in the other platforms compared to the other platforms as well as is very clearly underlined in his cases, it is partially retrievable valve because you inflate the balloon, and if you don't like the position, you can pull back the valve inside the sheath. Or, for example, you cannot pass through the valve, and then you didn't make a predilation, you cannot pass through the valve, you can take the valve inside the sheath again and make a predilation and put the valve again.
Okay, so it's versatile. Good.
So yes.
So, and I think we just predilate it with the dilator, right?
Yes.
So.
Yeah, for large sizes, you have to use a second dilator of 18 French that is in the package. 24.7 probably you can get away without it.
So here it is, the valve.
So it's a normal cribber, right? Or there are
It's standard crimping process. It's actually very fast to prepare the valve.
Here we use the Innovi wire. Do you use a different wire? Do you use a Safari? Will make a difference?
I use the Innovi most of the cases.
Okay.
If I need more support, I change to Landerquist.
Okay, good.
We use the Innovi actually. So we advance the valve actually.
Oh, this is the balloon?
The balloon, sorry.
So this is a different balloon than the ones that we use, the Numets and the Sipkas. Do you have experience with the Mammoth balloon?
Mammoth.
The Mammoth. It's a different kind of balloon. It looks like an Atlas, but it's not. So it's yeah.
It behaves quite nicely, stable in position, inflates and deflates fast, and there's this middle marker to facilitate your positioning as well. Well, that's the interesting thing, though. The valve is pre-mounted, and you can just push it in.
Yes, pre-mounted.
And most of the times you need to perform the Kochaeli maneuver, named after Theo. So it's.
You make me very honored here again every time.
I think I have coined the term for you. So it's actually when you have some difficulty in advancing the valve, you give maybe 10 to 15 cc's of propofol, and everything is smooth after that. Do you use propofol inside the sheath, Greg?
Well, we used to use it in the early version of the Sapien.
Yeah.
We couldn't go through it. Then we have Anna that haven't used it for a long time.
Yeah.
Now it's a
Yeah. So it's a new name, a new iteration of the old method. So it's good.
So it's done.
You see a good result.
It's small insufficiency.
I think you had some central AR there from the wire.
But I think it's the wire inside.
Zero
so,
implantation.
But then we pre-dilate, we post-dilate. We pass through the wire.
One tip that you can do if your valve doesn't cross is inflate, give 1 cc to the balloon of the valve, and that smooths your tip. Because usually there is this abrupt border between the frame and the nose cone. But if you inflate your balloon a little bit, then it makes it a lot smoother. In our cohort of the landmark trial that we implanted, in the MyVal cohort, there was 0. But we pre-dilate quite a lot. Yeah, in the balloon expandable cohort.
Nice result.
So it was a good result. I think it's very interesting that you have all these sizes, especially when you treat your younger populations, when you have this annular valves, be it like the MyVal, the Edwards, especially the Resilia platform, and also the Navitors. If you have, maybe we discussed in the morning with Finkelstein and Roxana Meran. So maybe, of course, we talk about we were talking about lifetime management and its and the patient's preference. All this should be taken into account because there's this critique about the TVT registry that a lot of these patients, younger patients, undergoing TAVI procedures. So, but maybe it's a lot of these patients in the TVT registry, the less than 65 years old. These are other; they have other comorbidities as well. It's not like only their patient preference, but still, if you are 65 and you're talking about lifetime management, maybe you can proceed with an annular valve, and the second valve would be a supraannular.
The big advantage of having all these options now is the financial issue. You don't mention it, but it will, just put the pressure on the companies to drop the price. We already see this in Europe, like in the US is a fixed price, that's it.
Yeah.
You put one or the other, but if we have more options, then we can save it. So that would be another benefit for the healthcare system and also the patients who pay.
Okay, so since we're talking about valve competition, and Ilias Kosmas is going to